Good evening, everyone, and welcome to the Health Equity Grand Rounds Echo. This is the first of a six-part series exploring racism in medicine, health equity, and COVID-19 in Alaska. This echo is jointly provided by the Alaska Black Caucus and UAA Center for Human Development Echo Project with support from grant funds awarded by the Municipality of Anchorage, Anchorage Health Department. My name is Erin, my pronouns are they, them, and I am an ECHO coordinator with the Center for Human Development's ECHO project. I'd like to go ahead and invite Deanne Woodard from the Alaska Black Caucus. Deanne, are you here? Is Deanne still having login issues?
It looks like she is.
Okay.
I'm sorry. It looks like she's having some problems still. So I will go ahead and introduce myself. I'm Celeste Hodge Grouden, President and CEO of the Alaska Black Caucus. The Alaska Black Caucus is the premier nonpartisan 501c3 nonprofit organization working to assert the constitutional rights of African Americans in Alaska, recognizing that racism is a public health crisis, which was only amplified by the COVID-19 pandemic. The ABC partnered with UAA's Project ECHO to deliver a Grand Round style health equity series. Grand rounds are historically, as you know, a part of the medical education in which clinical reasoning skills are enhanced under the guidance of expert clinicians. And the Alaska Black Caucus wants to use this framework to create a forum for Black community members and the BIPOC community and experts in various fields to connect with healthcare providers, leaders, and trainees in order to address racism in medicine, disparities in COVID-19, and work toward our shared goal of health equity in Alaska. This project is one of many strategies that the Alaska Black Caucus is using to decrease racism-based health inequities in our state. So I appreciate this opportunity and thank you so much for being here.
Thank you so much, Celeste, for that introduction. So participants, if whether or not you've joined in on echoes before, it's important to know that engagement with the group is integral to the all teach, all learn philosophy that underpins our program. So we encourage everyone to ask questions and make comments during the session by utilizing the chat box, or when appropriate, by unmuting yourself and sharing directly with the group. You're also welcome to private chat the session host, myself, or our hub team if you'd like your questions shared anonymously. During our session, we're happy to offer CME, AMA, PRA Category I, and Nursing, ANCC credits for our series. In order to claim these credits, you must attend our live session for at least 90% of the full session time and complete an evaluation, which will be linked in the chat at the end of our session. And once you've completed that assessment, you'll be redirected to a JOT form where you can fill out and download your certificate for completion. Our agenda today includes a didactic and case presentations from Dr. Italo Brown on the history of racism in medicine and its implications for COVID-19 outcomes and the influence of racism on healthcare and ethics. But before we get started, let's go ahead and have a few Zoom reminders. If your internet connection does not support audio, in the chat box you can find a phone number to call along with a meeting ID. Closed captions are automatically generated and available by selecting the CC button on the bottom of your Zoom screen. We also ask that you please take a moment to turn on your camera so that we can all get to know each other. The camera icon is on the lower left of your screen. And we do ask that you keep your mic muted during our presentations and when you're not speaking. You can mute and unmute yourself by clicking the microphone icon also on the lower left of the screen, or by pressing *6 if you're calling in via phone. All right, so to help further build connections and foster participation throughout our ECHO, we'd like to start each session with introductions. So we'll, hub team, as I call on you, please introduce yourselves with your name and pronouns, your role and organization, and what informs your passion for health equity. Participants, feel free to share the same for yourselves in the chat box. We welcome the opportunity to know you just a little bit better. All right, let's go ahead and start with Dr. Mendoza, if you would.
Good evening, everyone. Thank you for joining us. My pronouns are he, him, and I'm a family physician based in Anchorage, Alaska, and caring for patients in both the state of Alaska and the state of Colorado. And what kind of drives me is just my passion for achieving health equity, I've dedicated my professional career, and I think direct patient care, advocacy, and education are some of the best ways to help make impacts in health equity. And one quote that I wanted to share with you guys that kind of is my North Star with my work in the domain of health equity is from the late Edward M. Kennedy. And he said once, every American should have the opportunity to receive a quality education, a job that respects their dignity and protects their safety, and healthcare that does not condemn those whose health is impaired to a lifetime of poverty and lost opportunity. So I just wanted to share that with you. Thank you.
Thank you so much, Dr. Mendoza. All right, Ken, if you could introduce yourself. Thank you.
Great. Good evening. I'm Ken McCoy, and it's an honor to be here with you tonight. I'm a recently retired chief of police, and I'm currently the chief diversity, equity, and inclusion officer for Providence, Alaska. We all know that healthcare disparities impact people of color and other minority groups at alarming rates. The lack of access, the quality of treatment, and favorable outcomes must be improved. I'm hoping that through these conversations, we can identify the barriers and find solutions to bring true health equity to the underserved. Thank you for having me.
Thank you, Ken. Let's see here, Dr. Weiss.
Good evening. Thanks for having me. My name is Tracy Weiss, and I'm a psychiatric and family nurse practitioner. I use she, her pronouns. And I'm currently the clinical director at Identity Health Clinic, which is Alaska's only nonprofit clinic that services the LGBTQ2IA+ community. And I'm passionate about healthcare equity because members of my community are marginalized out of the healthcare system quite frequently. And that includes data collection, evidence-based, which means we don't always have evidence-based practice. And we know even within our community, there's a disproportionate burden of those impacts on people of color within the LGBTQ community. So I'm truly here to listen and to learn, to help start, guiding what we can do with the clinic to make sure that we are equally addressing the healthcare disparities for all members of our community, but especially those that are people of color. Thank you for having me.
Thank you. LaShonda.
Hello, everyone. Excuse me. I'm LaShonda McGowan. I am a clinician at Alaska Behavioral Health. My pronouns are she and her. And I am interested in this, of course, because I've experienced some health inequality, as well as my family. And I just know that there needs to be more awareness brought to the topic, discussion, and some change that needs to occur. So I want to be a part of that whole process.
All right, thank you. Dr. Alu. Obi, could we get your intro?
Yeah, I'm so sorry. Hey, good evening, everyone. My name is Obina Alu. I go by Obi. I'm a pharmacist, currently in the journey of transitioning to a legal career. And my pronouns he, him. The reason this topic is really something that I'm passionate about is because as a child of immigrant parents, we all know how socioeconomic disparities intersect with health delivery and also health outcomes. And that's something that as I progress in my career, I've been uniquely positioned to be able to see from the outside looking in, as well as the inside looking out. And there's a quote by Thomas Carlyle that I want to share with the group that I think really speaks to how I view this topic. He says, "He who has hope has health, and he who has health has everything." And for me, the hope is for equality when it comes to health delivery and how that translates to health outcomes, especially in communities, minority communities.
Thank you so much. Dr. Amanda.
Hello, good evening. My name is Maddie Mandap. My pronouns are she, her. I'm happy to be here on the Hub team. I'm a pharmacist at primary care at South Central Foundation here on Dena'ina land. We serve Alaska Native and American Indian people. What drives my passion is that, I guess, my lived experience as a Filipino American queer woman from California. I've always been interested in helping to combat health disparities and allying with other groups in order to achieve health equity Thank you.
All right, thank you so much. In the interest of time, we do have other folks that are involved in our organizing and planning. If you could share with us in the chat your information, we welcome that. But just to keep us on time, we're going to go ahead and move along in the session. So, all right, a few final reminders before we get started. The opinions of our hub team members and presenters are their own and do not necessarily represent those of Alaska Black Caucus, UAA, the Municipality of Anchorage, Anchorage Health Department, or any ECHO sponsor. Additionally, Project ECHO is not HIPAA compliant. Therefore, we ask that no protected health information is to be shared or displayed at any time. And finally, I also want to acknowledge that the subjects we're discussing here carry weight. As we will explore during our series, racism and its impacts are not abstractions. They exist materially, bodily, emotionally, and spiritually. I invite those joining in on today's discussion to do so with that in consideration, to listen, to keep questions and comments on topic, to be considerate, and to use language that is respectful, especially when in response to those with lived experience and expertise. Thank you to everyone for following those guidelines. And without further ado, over to Dr. Brown. Dr. Brown, if you wouldn't mind introducing yourself a little bit and then kicking off with your presentation. Thanks so much for joining us today.
Certainly. Thank you, Erin, for the introduction. It was wonderful hearing all of the different members of Hub introduce themselves. I see us all as allies in this work, and more importantly, as leaders in the space that has been for many years overlooked and undervalued. So, just to be here is a tremendous honor. If you guys bear with me, I'm going to set up my presentation, okay? And I've marked it down to 37 minutes as just trying to be as concise as possible in the time frame that we have, because I know that it's a heavy conversation to have, and we've got two parts of it. So, all right. So in a second, I'd like you guys to let me know, or everyone to let me know what they see. Hold on. So right now it should just be my presentation, and let's switch these. Do you all just see the presentation at this point and not my notes?
Yes, you're good.
Fantastic. All right, I'm setting up my timer. Okay. So today the conversation is called The Elephant in the Room, How Race and Racism Impact Medicine and Healthcare. My name is Italo Brown. I'm an emergency physician, but my technical role or faculty role is as assistant professor in both social emergency medicine and emergency medicine at Stanford. I also serve as a social justice and health equity curriculum lead for the School of Medicine, where I pretty much work with a team to develop social justice and health equity content and infuse it into the medical school curriculum. Just wanted to, before we get started, give a brief disclosure. I have had previous engagements with these companies. They've all ended since then, and most of them have been in the capacity of sharing insight around health equity issues so that they value them. We already had, Erin did a fantastic job of originally kind of setting the tone for this conversation. I want to reiterate that this is a zone of safety. We also do trigger warnings typically in these conversations so that people realize that, this is very sensitive information and people may re-experience trauma or relive prior trauma just by having this dialogue. I would also take a moment to admit that biases are going to exist here. I acknowledge my bias. I'm still learning about my biases specifically as a cisgender male with a heteronormative bias. I also tend to focus on the anti-Black sentiment in my presentations. And I do think that this is something I learned from, as well as sharing with others. But hopefully what I share with you all today, the skill sets and the things that we discuss can be applied to all frames of identity. In terms of discrete objectives for this conversation, I'd like to narrow it down to three things: describing the problem, examining the drivers, and identifying strategies. By describing the problem, what I mean is we need to understand the language of health equity, defining race and racism, differentiating things like social drivers and determinants of health, health disparities, and health equity. Then we're going to look at those drivers a little bit more discreetly, where we discuss the systemic and the structural effects of racism on medicine. and examine the relationship between racism and poor health outcomes. And finally, we're going to tailor into identifying these strategies where actions that are anti-racist will be discussed, and really how they improve health equity at a larger scale as well as an individual scale. So let's get right into it. How do we define racism? You know, this is a substrate level concept. We have to be able to, at a very foundational level, know these terms if we're going to seek to improve this situation, or rather this circumstance. So race is defined as a socio-political construct or a categorization system forged historically through oppression, slavery, and conquest. Now, these terms initially were separated, right? They were separated to designate race as a biological quality and ethnicity as a cultural phenomenon. So think back, originally, race is strictly supposed to be something that is a biological categorization tool, whereas ethnicity is more so considered to be cultural phenomenon filled with practices and specific, and can be as deep as a spiritual connection to that particular category. Racism, however, is essentially defined as this belief that groups of humans possess different behavioral traits corresponding to inherited attributes. And because of this, they can be divided based upon superiority of one race to another. This is the absolute foundation of racism in America. We want to give you some historical context. And the reason why I go through this is because we can see a chronological development of racism, or really how race has transformed into racism, how it's been justified, and where we're at currently. So let's think back to the 1700s. I know none of us were present, but it's good to actually have that type of a historical context. In the 1700s, you get discussion of the climate theory, where thermal association is connected with skin colors. But also you start to see the development of the curse theory. And this is of biblical origin, right? So the story of Ham and how there was a specific skin color rather, that was thought to be due to leprosy. The shift from climate to curse theory takes place around the American slave trade, and it helps to justify the behaviors of the early slave owners. Then in the 1800s, this is the back end of the Enlightenment era, right? The Age of Enlightenment, where you start to see more scientific understanding of these differences. So the development of polygenesis versus monogenesis. Polygenesis being the belief that there was a descendant of some type of primate origin rather, right? So Africans being the descendant of primates and having more of an animal or mammalian origin. Then monogenesis. This is the development of one origin, but within that specific origin, there's hierarchy. There's totem pole style hierarchy in that construct. And prior to this stage, you don't get the use of the words race and species. But at this stage, you start to see race and species being used interchangeably, which is very important to note. In the 1900s, we get the emergence of scientific racism with a eugenics movement, right? So we'll talk about an individual named Sir Francis Galton a little bit later, but he is considered the person who invented the term eugenics, and also is considered to be one of the contemporaries, or rather someone who contributed a lot to the work of Charles Darwin. So out of Darwinism, we get this belief that there's inherent superiority of some races over others. Then let's fast forward to what we may be more familiar with in the 2000s with the Human Genome Project, which establishes that genetic differences within any designated group are probably greater than the differences between racial groups. So it basically debunks 300 plus years of rationalized treatment based upon skin tones and race. Recently, if you've been paying attention to things that are going on in the southern US states, a lot of conversation around critical race theory. And it's also been used in a way that's more politicized than actually knowing what it is and what it seeks to accomplish, right? So let's define it. critical race theory is an academic framework. It's an academic framework that acknowledges race not only as a social construct, but it acknowledges this premise that racism is more than just individual one-on-one prejudices. It's more so embedded in larger systemic issues like the legal justice system, even our healthcare system. Some automatic examples that I could think of where critical race theory has been applied and is used as an educational tool is understanding things like the discriminatory practice of redlining, right? Where residential racial segregation has been found or shown to be a powerful predictor of Black disadvantage and poor health outcomes for ethnic minorities, specifically things like asthma and preterm birth. Or consider police violence in the carceral state, where increased policing and increased incarceration have profound adverse consequences for the health of Black people. And then finally, what's probably the most relevant to us is just unequal healthcare, where we see that the establishment and reinforcement of an American medical caste system is what exists, and Black individuals are routinely receiving substandard, suboptimal care, and it's evidenced on our health outcomes. I am very passionate about being surgical with the terms that you use when speaking, because you may only have one opportunity to influence a policymaker, to influence a funder, to influence someone who can absolutely amplify the work that you do. So let's make that very clear here. Social and structural drivers of health, formerly social determinants of health, right? So the latest iteration is social and structural drivers. These are the non-medical drivers of health outcomes. You guys with me? Just making sure. Good. Non-medical drivers of health outcomes. So things like access, transportation, employment, insurance, income, right? These are we talk about them pretty commonly, and you're familiar with them as well. Health disparities. So health disparities, these are discrepancies in health outcomes. And you have to take two groups and compare them, or multiple groups and compare them, to be able to speak about health disparities. It's usually categorized or usually a comparison based upon different variables, things like race and ethnicity, gender, identity, ability, and sometimes geography or socioeconomic status is used. I've even seen proxy indicators like insurance status used, okay? Then there's this concept of health equity. Quite plainly, health equity is the expectation that every person, regardless of the group that they're classified with, can achieve optimal health outcomes. But there's a huge difference between using the word equality and equity. And we often hear them used interchangeably, but we have to make these terms crystal clear. Equality and equity sound similar, not exactly the same thing. If I were to give you some definitions, equality is all stakeholders get the same resources regardless of the circumstances. And then equity would be the circumstances informing the resource allocation to ensure that to ensure that there's an equal opportunity for good health outcomes across all the stakeholders. I have this picture here because I think that it's a good analogy, right? So if you're looking at a track and field, you're looking at the track. When you see the numbers marched right across from one another, all of them lined up at the same space, that represents equality, right? Because everyone starts at the exact same place. But when you think about the distance, that innermost lane runs a shorter distance than the outermost lane. So in order to enforce equity, you stagger the lanes. So there's an even way of saying that everyone's running the same distance. This is a very loose way of interpreting it, but I like this way a little bit better than the standard image with the kids peering over, a fence looking at a baseball game. This way, I think, helps others understand that concept a little bit. So we've gone through a lot of the language, and it comes down to knowing how to use it, when to use it, and being able to describe those elements to a T. So we'll talk a little bit more about racism now. How does racism affect how we learn? And this is something I'm passionate about because as someone who works on curriculum, who directly sees the downstream effects of the way we educate one another, we have to acknowledge that racism has been woven and embedded into the fabric of our education for about as long as we've been educated. I come from the lens of a medical practitioner, but this can be applied to anyone who has worked in healthcare or has taken a biology class to any depth, right? We think about some of the key influences in medicine. I've got 4 pictures here. Obviously, off the bat, you can tell that they are all older white men, which by itself is a first red flag. But I want to get a little bit more granular with you all. The picture on the left, the gentleman that's in color, this is a picture of Dr. Benjamin Rush. Dr. Benjamin Rush is one of what we would say the founding fathers, right? And when you look at the Declaration of Independence and how it was signed, he's one of the names that signed it. He's also former Surgeon General of the Continental Army. His claim to fame are those things, but when we think about medical education, he also was a strong proponent of the idea that the Negro color was due to leprosy. Okay. Let us move one over to Mr. Sir Francis Galton. He's the second picture on the left. This is the individual I named earlier when I was talking about eugenics and how in the 1900s we get this emergence of eugenics. He's the father of it. Again, he was somewhat of a researcher that published vigorously about this topic and influenced the minds of Charles Darwin. Then second from the right, we have Dr. Edward Jarvis. In 1841, Dr. Jarvis was published in the New England Journal of Medicine, concluded that slavery had what he considered to be a wonderful influence on the intellectual power of Black people. So leading journal, this is what he's published saying. And then finally on the far right, for my friends here who are into neuroscience or neurology, this is Pierre Paul Broca, famously known for Broca's territory or region in the brain, right? Contributed a ton to understanding physical anthropology and the science of anthropometry and reaffirming these theories that Blacks were indeed inferior based upon sizes of brain, measurements within certain parts of the brain and the skull sizes. So this is the backbone of our medical education. And these are just 4 people, but I'm sure we could find other pictures and other specific lineage of racism within medicine. But now let's talk actual events. So we talked about people, now on to the events. This top left picture here, this is the picture of someone being auctioned off at a slave auction or slave trade. This is a clear historical reminder of where and how Black bodies were devalued. Automatically, this set the standard that Black bodies were subhuman. The bottom left, this is a rendering of Dr. James Marion Sims, who many consider to be the father of obstetrics and gynecology. Between 1845 and 1849, he kind of rose to prominence because of his procedures, right? One of the procedures we still do today, which is essentially a vesiculovaginal fistula repair. This operation was perfected on Black women, A, without consent, and B, without anesthesia, because the running belief was that Black people didn't feel pain the same way, a belief that has been documented to still be held up until maybe 2016 among medical students in the US. The center black and white picture, which looks like a newspaper clipping, is highlighting that between 1850s and 1890s, we saw an uptick in the robbing of Negro grave sites for medical cadavers. So the training of our best and brightest clinicians down in the Medical College of Georgia, but probably not limited to that institution, was from going to Negro grave sites, digging up the bodies and practicing procedures and learning anatomy via those. In the top right, this is the most well-known example or historical influence, Tuskegee syphilis study. It's in the last 2 years, I'm sure that there's been more conversation around it than the previous several decades. But this is how we understand the natural course of syphilis. It comes from seeing Black bodies deteriorate, specifically Black Southern men. And then the bottom right, this is a nod to the Cincinnati radiation experiments at Holmesburg Prison, where they learned about the effects of radiation by testing them on predominantly Black inmates. A quick chronological brief course through education, right? 1847, we get the first Black medical school graduate, who ironically graduates from Rush School of Medicine, named after Benjamin Rush, the gentleman we showed 2 slides earlier, who believed that the Negro color was due to leprosy. In 1850, we get Martin Delaney, this gentleman pictured here. He, along with 2 other students, gain acceptance to Harvard Medical School, a prestigious institution. The entire class, except for those 3 individuals, petitioned to have their non-Black classmates dismissed and are successful. In 1876, we get the first Black medical school accredited. It's my alma mater, Meharry Medical College. I'm proud of it, but we were far from receiving equal resources in the city of Nashville. 1895, the creation of the National Medical Association. It sounds like a bright spot for clinicians of color, except when you realize that this was born out of necessity because the AMA didn't accept people of color. And then finally, 1910, Abraham Flexner, the Flexner Report. This, by many individuals, is heralded as one of the hallmark or staples in medical education because it created a standard for medical schools to even be open, right? 5 out of 7 Black medical schools were closed as a result of this report. And it was also suggested that the reason why the 2 remaining were there was because they were to produce sanitarians to protect white communities from deadly diseases like TB. Finally, we get the Brown versus Board of Education landmark decision, 1952 to 1954. And here we understand that now racial segregation in public schools is considered unconstitutional. However, this ruling comes 100 years after the first Black person ever enters medical school. So just chew on that for a second. We have race-based medicine. This is algorithms that factor in race, things like glomerular filtration rate, which I'm sure you have heard a little bit of because recently this has been the most prominent use of race-based medicine. But it doesn't stop there. There are other measures that we have, even medications like Bidil, which were based purely out of racial differences. Spirometry. This is a practice that we often talk about from an educational sense, but also when we try to understand lung function and lung disease in different communities. But if you knew that lung testing, spirometry, came from a gentleman named Dr. Samuel Cartwright, who basically added in a race factor and showed that Blacks had a decreased lung capacity by like 20%. Here's a picture of some of the stuff that he said. Soldiers classified as white had higher lung capacity than those labeled full Blacks or mulattoes. This device was previously used by plantation physicians to show that Black slaves had weaker lungs than white citizens. And then finally, forced labor was seen as a way to vitalize the blood of flawed Black physiology. And by this logic, slavery is what kept Black bodies alive. I know that's a lot. And we got about 16 minutes left to dive in, but I want you to understand that we have to go through the rough patches in order to be able to come up with solutions on the other side. Let's talk about what's relevant to practice. So we've talked about the language. We understand how we were educated and how racism was very insidiously and sometimes very blatantly woven into the work that we do. How does it affect how we practice? Well, one, there's a development of implicit and explicit biases. This is not limited to communities of color. This is across the board. And I acknowledge some of my biases just at the beginning. But we must understand that implicit biases are activated by a subliminal prime. Environment, situations, things that we have lived, that's what helps to encode or rather codify this implicit bias. It gives rise to the othering phenomenon where we view or treat people as intrinsically different or alien to ourselves. And a good friend, Dr. Quinn Capers, made a comment, and he said that it is important to distinguish implicit or unconscious bias from other conscious beliefs that certain demographic groups are inferior or less deserving of others, of opportunities. These are examples of explicit, not implicit biases. Although a person may harbor both explicit and implicit negative biases about a certain group, it's possible to be consciously be egalitarian in one's views while holding negative implicit biases about certain groups. This is the inconvenient truth about implicit bias. Good people can unknowingly discriminate. Microaggressions. I know that in the last year, I've heard more conversation around implicit bias and microaggressions than I had in the previous 10 years of my education and career and training. But microaggressions, they have profound impacts on marginalized communities, people from historically marginalized backgrounds, right? We see that there's a higher incidence of reporting microaggressions, higher prevalence of racial bias and discrimination among Black medical trainees. This contributes to high degrees of burnout. Then there's the development of imposter syndrome, which we know affects ethnic minorities, women, marginalized groups to a very high extent. And then there's known physiological and psychological effects of racism that compound these things. We'll talk about those in a second. At the group level, so we talked about at the individual level, but at the group level, we recognize that a lack of diversity in medicine leads to the feeling that you are alone. I have a graph here that demonstrates that in the most recent graduating class of US medical graduates, there were about 6% Black, it was about 6% Black, whereas the US population has about 12 to 13% Black. So there's a clear discrepancy between those numbers and the representation. But that exists throughout all levels of training. It even dwindles when you get to the ranks of faculty and departmental leadership. We see about 5.5% of medical faculty identifying as Hispanic or Latinx, 3.6% as Black or African American, and 0.2% as Native American or Alaskan Native. There's an institutional level effect where we see that there is a higher incidence of low quality, high cost hospitals receiving Black patients. Whether it is social drivers of health that affect their ability to access the optimal care from the institutions that may be considered centers of excellence, what it ends up as is because you may not have insurance or there's a perception that you may not have insurance, you end up in hospitals that are often understaffed, don't have all the specialty services there, usually are more so training sites for individuals who may practice medical tourism. And then finally, funding. At the institution level, like I said, we see this, this lack of funding for community-centric activities, community-centric programming. We know that there's differential funding in terms of R01 grants. We know that there is a clear difference in terms of topics that are considered fundable by the NIH. And it's interesting that you can even be a person of color writing about issues of health equity and be less likely to receive a grant fund than a non-Black, specifically a white colleague. There are fewer Black physicians, fewer people of color on editorial boards of the highest impact journals. In fact, the JAMA editor, in what he considered to be a misquote, but rather more so a misunderstanding and maybe a just lack of understanding, minimized the presence and the enduring effects of systemic and structural racism on a podcast last year. So our practice is the lens through which we understand, and the filter is the education. So how do we see patients affected by these compounded elements? Well, it's really interesting because you see these patients, and I believe that the things that we share in this next segment, you can attest to firsthand. So racism acts as an amplifier, right? We can see that there is data to support elevated levels of cortisol, elevated inflammatory markers, higher blood pressures. So hypertension seems to run rampant in communities of color and among marginalized populations, but it's not strictly explained by genetics, right? It's more epigenetics, but it's not 100% explained through just what we're eating our dietary choices or our lifestyle choices. It's a modifier, an amplifier of these things. Elevated heart rates, tachycardia, more common among communities of color because, again, there is an added element which we believe could be associated with racial discrimination. The literature also supports there's an association with psychological effects. So anxiety, depression, resting anger and paranoia, frustration, and then post-traumatic stress, right? With poor exposure to coping mechanisms and even more so limited mental health specialists in communities of color, obviously this can lead to what's considered more serious mental health diagnoses, if they're even diagnosed. Health outcomes, we know, differ clearly along racial and ethnic lines. Black and brown communities seem to be disproportionately represented among all of the leading causes of death in the United States. And while social determinants of health tend to provide some support for these differences, it doesn't really explain the disparities entirely. We've heard the stories about pain management gaps, where Blacks are less likely to receive opiate medication in an emergency department with the same type of diagnoses on the back end as their white counterparts. Cardiac outcomes, seeing that Blacks are less likely to be taken to cath or have a catheterization activation. Hallway beds. I'm not sure if you've seen this, but when you take a look around inside of a busy hospital, the faces that are in hallway beds tend to be the indigent, those who have housing insecurity, those who are of ethnic minority background, or those who do not speak the language of the majority of the care providers there. So there's a bunch of other things that I can go down: novel cancer therapy, a referral for kidney transplant services, hospice care, substance use counseling. Each one of these things, the data supports that there are ethnic differences and disparities are real, reproducible. The most stark one to me, and the one that I think is calling for our immediate attention, is maternal mortality rates. We know that Black women in the United States are have a 4 to 5 times greater mortality rate than white female counterparts. And some believe this is largely due to bias. You could literally be a relative who works at a convenience store and have the exact same mortality rate as Serena Williams or Beyonce Knowles, simply because of color. And we know this because both of those superstars have reported having differential experiences related to their pregnancies. It's well documented in the literature, but it doesn't get enough emphasis. I have this graphic here to pretty much show the process of how we see racism modify things. Individual racism gives rise to collective racism. Then we get the development of systematic and institutional racism. Now, at this point, social and structural drivers of health can act as somewhat of an incubator, can amplify or can nurture that racism. Then systemic and structural racism follows that, which all contribute to changes, increased mortality and morbidity among communities of color. No greater pressure cooker situation than the past 2 years, where we've seen this unfold before our eyes with COVID-19. Black and brown communities were decimated in comparison, and it was because of a long, or rather a chronic, under prioritization of several things: social drivers and systemic and structural racism as a modifier of health outcomes. We saw that the likelihood of being co-housed or working in an essential worker capacity, or living somewhere where you were distanced from optimal care, or not having testing centers, these things tended to follow the same patterns of what we've known for the last 50 years when it comes to health disparities. So in the wake of, or I don't want to say the wake, because we're still in a pandemic, but in the substance of a pandemic, we see that there is a troubling dynamic between health and ethnicity. And sometimes this dynamic is fragile, where in other times it breaks completely. And when it does, we get questions around mistrust. Now, I can remember when my father told me, as soon as the pandemic started, I spoke to my father and I said, hey, I need you to follow these rules. I'm sending them masks through the mail. And then we get the vaccine. And I'm like, well, this is great. You're going to be eligible. And my dad just absolutely refused, absolutely downright refused. I tried for probably about 10 to 11 weeks to convince him. And finally, on the last week, he said, I'll do it. But unfortunately, in that same week, he got COVID. Now, he was fortunate enough to survive it. But what I'd like to draw emphasis to is, as a Black man who is 70 years old, he lived through so much of the medical mistrust or the roots of the medical mistrust that even his son, who is a physician, could not convince him in a dire crisis to trust the healthcare system. This is not a unique story, because I'm pretty sure that if I ask multiple community members, they'd be able to validate these particular experiences. What it boils down to is understanding things that Toni Morrison understood. And I heard the quotes being shared in the beginning. I'd like to share one of my own that comes from Toni Morrison. The very serious function of racism is distraction. It keeps you from doing your work. It keeps you explaining over and over and over again your reason for being. So how do we move the needle? We've got about 3 minutes left, so I want to make sure that I give this some justice. 3 things. We hear conversation around anti-racism, diversity, equity, and inclusion, and restorative justice. But what does it actually mean in terms of steps? For anti-racism, this is an acknowledgement. We have to outright prioritize the acknowledgement that systemic and structural racism is baked into medical education. It impacts every single element of healthcare delivery. And if we choose to be equitable, it starts with acknowledging this relationship. Diversity, equity, and inclusion is really about representation, but it's more so thinking that if we underaddress this dynamic, we will have what we've had for the last several centuries, where there's significant health disparities and health inequity on the back end of underaddressing it. And then the restorative justice, this really comes down to just responsibility. Taking ownership, taking responsibility of our collective missteps, and broadly initiating this restorative justice movement within medicine to regain trust, not just of one another, but really within the communities that we've marginalized. And they're often the most vulnerable people. The key here is that none of these actions are popular. None of these actions can be performative, and you have to do so at the risk of knowing and exposing that it disrupts the fabric of power and privilege. Finally, I want to tell you these last 5 things that I think would help in the last 2 minutes. 1, expanding understanding of systemic and structural racism. That means in the breadth and the depth of the conversation, we have to have a greater understanding of this. As I said, prioritizing restorative justice, thinking about trainings on implicit bias, microaggression, and upstander actions, but really diving into the content, making it available widely, and ensuring that critical race theory conversation is woven in at medical education level. It'll help our clinical decision-making outright. Initiating policy reform. It requires looking with a fine-tooth comb over in-house and external policies that are bad and that worsen health outcomes. We got to champion the advocacy efforts at an institutional, local, and state, as well as a federal level, and from within, groom the equity-minded advocates that are native to our institutions. Prioritizing pipeline development and sustainability. I showed you the numbers. It really comes down to hiring diverse senior leadership, making sure that there is mentorship and sponsorship threads available, and also really emphasizing going to historically marginalized communities with a longitudinal commitment to ensuring their presence at every step along the way. But it can't stop there. The culture in these places have to change and make sure that equity is something that is prioritized. Investment in DEI initiatives, specifically ones that target the health and wellness of those, both within the system and external to it. So I encourage that we acknowledge mental and physical well-being of our underrepresented colleagues, because they are perpetually under fire. Now, more than just mental health and gym memberships, this requires the creation of internal community, strengthening one another, safe spaces, and constructive outlets. And finally, pouring dollars. That means absolutely funding task forces and financial support for folks inside who have clinical programs that seek to be champions for underserved and for vulnerable communities. And then finally, this is my last one, community engagement and investment. That just basically means we have to bring all our community members to the table. They are stakeholders, and valuing them as such because they have a wealth of knowledge that most clinicians don't have. We should activate our community champions and form trusted messengers within that rank and pay for them, compensate appropriately for the knowledge that they bring to the table. So I've spent some time describing the problem, discussing its drivers, and identifying some strategies. And my hope is that this helps to develop your lens, but more importantly, serves as a catalyst for action within organizations and within medicine itself. All right. That said, I think I may have just hit my mark.
Dr. Brown, incredible. Thank you so much. So folks, we are running a little bit behind, but we do want to take a few questions before we move into the case presentation portion of our session. Dr. Alou, would you like to go ahead and lead our Q&A session now?
Yeah, thanks so much, Erin. Thank you again, Dr. Brown, for the wonderful presentation and all the wealth of information that you shared this evening. Hopefully everyone found that helpful and very enlightening. So it looks like there was a question that came up in the chat from Chris Dirth that said, what would make pulse oximeters give bad data in African Americans?
I'm pretty sure that it had to do with the pigmentation, right? The pigmentation, I think that the fact is that the saturations were different based upon darker pigmented skin, and there was not supposed to be a corrective factor, but there were individuals of color who were essentially getting lower readings from pulse oximeters. And because of that, there were advanced treatments kind of like given without real understanding of it. I don't think that I've ever treated based upon a pulse oximeter, so to speak. I believe more so in Italo. That's just me personally, but I think that in the early parts of the pandemic, there was an over-reliance on looking at pulse ox, and also because it was easy to get. And that led to a lot of people being falsely intubated.
Great, thank you so much. Just want to, due to the interest of time, I'll just share one more message we have in the chat, and then we'll move on to the case presentation. So it looks like Allison Horgan wanted to give a shout out to Providence for implementing a race-free EGFR. And that is something that Dr. Brown also touched on his presentation tonight. For anyone else that has any comments or questions that they would still like to share, feel free to put that in the chat box. But for the interest of time, we will move forward to our case presentation. Thank you again.